the presentation. So I'll move on to the last presentation, that is mine on surgical management of advanced Coats disease and familial exudative vitreoretinopathy. We'll see how much we can cover in the time that we have. So Coats disease is an idiopathic retinal telangiectasia and has been classified broadly into five stages. And the role of surgical management mainly comes in with stage 3B and stage 4 when you have a total exudative retinal detachment with or without neovascularization. So the role of surgery is debatable, but yes, we know from the natural history of the disease that if we are going to leave these eyes as it is, a majority of them are going to go into neovascular glaucoma, and a lot of them will require enucleation for a painful blind eye. So the aim of the surgery is actually to prevent that complication. The visual gain may not be as much, but you are actually trying to save the eye in its anatomy. So just one example, one surgery I'll show. This is a 7-year-old male child presented with right eye xanthochoria and exotropia for the last 6 months, was brought by the parents. And you can see that total exudative retinal detachment with those subretinal exudates. The telangiectasia are not actually visible here, but one thing that is most important in these cases is to rule out retinoblastoma. The age group matches. Most of the children who present with stage 3B and stage 4 are younger children. They are around 5-6 years of age or even younger. And those beyond 10 usually do not come to us with this kind of presentation as far as I have observed. So an ultrasound and a CE MRI brain and orbit are absolutely essential so that you can rule out retinoblastoma as surely as you can, and only then proceed with intervening in such eyes. Parental counseling is also important to get their expectations to what can be expected out of the case. Again, as I said, is to avoid a painful blind eye, and the visual benefit may be minimal, and repeated procedures may be required. And also that the exotropia will not be treated with this. So this is just a case. As you see, the retina is lying right behind the lens and those mobile subretinal exudates over there. So I put in a traction suture at the temporal limbus, and about 8 to 10 millimeters from the limbus, localized peritomy is done. Just a localized incision into the conjunctiva and the tenons to bear out the sclera over there, a small amount of diathermy so that there is no further bleeding. And then I prefer to do a direct cut down. Somehow with the cannula drainage, I am not very comfortable with going in the subretinal space. And an AC maintainer is put in at this time so that the globe is pressurized and the egress of the subretinal fluid is aided with the same. A direct cut down is done in the sclera. You have to manage the quadrants in such a way that when you are pulling the eye towards one side, your AC maintainer and the cut down are almost in the same quadrant. And then drainage with the help of a 26 gauge needle. You can see the refractile crystals coming out here, and it takes a lot of time to drain this fluid, and unlike scleral buckling, most often you have to keep your needle over there because that opening tends to close. The fluid is very thick. And then I just put in a chandelier. You can see most of the fluid has been drained. The retina is largely settled, but you can see these vitreous strands over here. So this is something that I have done recently, just going in with a vitreous cutter and kind of dissecting these strands, because post-operatively I saw that there was a lot of fibrosis happening in these eyes. And then you can see these telangiectasia interiorly in the inferotemporal quadrant, and a direct long duration laser can be done to these telangiectasia to treat the primary cause of the detachment. This is actually the most important step, and I prefer to leave just a small bit of triamcinolone at the end of the surgery that helps aiding the inflammation that is there and resolving the rest of the subretinal fluid. So this was the picture of the child 20 days post-operative. Now we have had experience with some of these cases where they do well, and of course sometimes require repeated interventions. Again, another exudative case that did well following the surgery. Another advantage is you can take a sample for diagnostic cytopathology just to be sure you haven't entered a tumor eye, and you can get the analysis for the same as well from the subretinal fluid. So important considerations, I think I covered most of these. I'll quickly go on to FEVR. We have a few minutes. So again in FEVR, the main indication for detachment comes in with stage 4 and stage 5 FEVR when it involves the macula. And Dr. Tracy was the one who showed us that yes, surgery can help in FEVR cases, though the outcomes may not be as good as others. So we would all like to have cases like this where there is no detachment yet, just neovascularization, and we can just laser them up. That is the most ideal scenario. But we often get these cases like this, as one-eyed child which presented with a combined retinal detachment and a lot of neovascularization and hemorrhage. So I'll quickly go through the surgery and we'll know what challenges we usually face in the same. So put in a 277 tire in the temporal half to support that, to give some extra support. And then started with the vitrectomy. You can see the retina is pulled up very anteriorly. The ports were going through the retina even at about 3.5 millimeters. So that is one thing that you need to take care of and examine preoperatively with a EUA. And then the hyaloid removal is actually very tough in these eyes. So use of triamcinolone and regular bimanual procedures also help. And you can see that you can just get it up to where the neovascularization is present. Beyond that, it is still very difficult. So the role of the encircling elements comes in very handy here. And they often have this kind of membrane right over the posterior pole that ultimately causes the falciform fold-like picture also. And removing that is important. And as we saw earlier, once you have dissected the proliferation or the hyaloid from the posterior pole, PFCL really helps as a third hand for further dissection. So even after doing all this, I decided to give a trial of fluid air exchange over here. But as you can see, this whole retina, the air went subretinal and the retina was kind of tenting up. So there's still a lot of stiffness in the periphery which was not getting supported. I tried doing the retinectomy under air to see how much relaxation would be required, but the retina was kind of flipping over. So went on fluid and completed the retinectomy for about 120 to 150 degrees. And then again put in PFCL, which settled the retina, laser and cryo to the anterior flanges, and finally PFCL air and air oil exchange. So this was post-operative. So I'm just going to finish here that yes, actually the incidence of FEVR is much more than we have seen. Early intervention with laser may prevent progression, and despite laser of almost 50% of these cases, the vitreopathy progresses and kind of forms traction and the detachment. Peeling of hyaloid from the retina can be extremely difficult, and anteriorly pulled up retina should be considered while entering the eye. And finally, do not forget the family. It is an autosomal dominant condition. Please examine the family members. They will have the same. And as goes with all pediatric surgeries, coats and FEVR, the lesser you can do and give the outcome, the better it is. Thank you so much.
Yes, one comment.
Yes, sir.
Yes, I agree with you. Rightly mentioned, when you're dealing with the coats, you need to rule out retinoblastoma. But we need to also understand Coats disease can have a ocular coat calcification as well. So you need to differentiate. Just because seeing a high reflective echoes does not mean that retinoblastoma is there, so that thing need to be kept in mind.
Right. Thank you.